To all who are new here, welcome. Due to COVID-19, we've moved our regularly scheduled in-person journal clubs to an online platform. Fortunately, our fearless head of the journal club and liaison with the VOC, Brittany, has been doing an excellent job at making this a seamless and very effective transition. We have over 250 athletic trainers registered for today's webinar. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or you can sign up for the email list to be notified of upcoming webinars. For all athletic trainers who are intending to get live CEUs from the BOC immediately after the webinar, complete the quiz, which will become available once the webinar has closed. In order to access this quiz, you must remain in the webinar until it closes. 1 hour after the webinar concludes, you will be emailed a link to the evaluation and assessment. You will have 24 hours to complete the assessment. Once you have completed the quiz and the assessment, and this has changed, you will receive your statement of credit via email within the next 2 weeks. So plan to receive that within the next 2 weeks. If you have any questions during this webinar, please submit the question and we will review them at the conclusion. So I'm thrilled to introduce our speaker today. Dr. Dusty Narducci is a team physician at the University of South Florida. She is the Assistant Director of the USF Morton Plant Meese Primary Care Sports Medicine Fellowship, and she is the head team physician of St. Leo University. She served in multiple roles with AMSSM, including her current role as the Public Relations Sub-Chair. She is also in the process of becoming a certified eating disorders specialist with the International Association of Eating Disorders Professionals Foundation. So I'm going to have her take it away, and I'm really looking forward to the talk that she has to give for us today.
Hey, Michelle, I might be having some technical difficulties. Can you guys hear me?
Yes, we can.
Okay, let me share my presentation. Bear with me. Ended up going from my home desktop to my laptop. And you let me know if you guys can see that. What are you seeing? There we go. Does that work?
All right, we're there.
Okay, everyone can see it? Great. Well, thank you so much for having me. I'm definitely one of your #1 fans. It's a pleasure to be here today and talking about one of my absolute favorite subjects in sports medicine. I kind of struggled a bit about what to title this presentation, but I'm going to go with less than optimal energy availability in the female athlete. Sometimes it changes to less than optimal nutrition. And as we go through this presentation, it'll make a little bit more sense. I was a little bit confused on what to call it. So I am who I say I am and who Michelle says I am. I'm one of the team docs for USF, as well as one of the team physicians for St. Leo University. I'm assistant director for the Primary Care Sports Medicine Fellowship at USF, and also part of their medical school as assistant professor. Just recently took on the role at our USF Concussion Center as a research director. And as you were talking about, something near and dear to my heart is called the Certified Eating Disorder Specialist. It's called a CEDS. If anyone ever has any more questions about this certification or what it entails, please let me know. But it's about a 7 to 10 year process, really being able to help all individuals from female athlete triad all the way to binge eating disorder, to obesity, anorexia, bulimia, all of that. So excited to be almost done with that. I have no conflicts of interest. So our objectives today, this presentation is directed to athletic trainers. You guys are the foundation of our sports clinics, as well as our training rooms, and it's exciting to be able to talk and learn with you guys. So I really want everyone to be able to interpret the history and literature of female athletes with low energy availability following this lecture, be able to recognize the athletes that are at risk, develop an understanding of the acute and long-term effects, regardless of age of the female athlete, and be able to apply these tools to recognize, diagnose, and manage them. So history is important. We have to learn from our mistakes in medicine. So I'm going to give you a little bit of a history. I previously presented this presentation way more in depth about the history after scrutinizing all the literature. But as Theodore Roosevelt said, the more you know about the past, the better prepared you are for the future. So instead of the 15, 20 slides that it previously was, I try to create the history into just this little nugget over here. So let's start with 1972. Title IX was created, and the point of this federal legislation was to really make it fair across different academics and things like that when it came to financial support for genders. So females and males got the same rights. There was an increase exponentially in female participation after Title IX in 1972. And then in 1977, this was the first actual real mention of a delayed menarche in high school, college, and Olympic athletes. So basically, they weren't getting their period as the same time as other females were. That was the first time we kind of had a hunch that, hey, maybe something's going on. And then in 1985, almost 10 years later, there was some treatment options for this. And the first thing they said was decrease our exercise, and nothing else was offered. And as we all know in sports medicine, that doesn't always go over so well. 1990, there became a relationship between estrogen deficiency, physical exercise, and bone health. So that finally started to get recognition. We realized that this was a bigger picture than we thought it was. And then in 1992, the American College of Sports Medicine coined the term the female athlete triad. There's a lot of other information in between there, but I'm going to get to the juicy stuff and skip that. So I can't even talk today. The American College of Sports Medicine created this term, the female athlete triad. So we break it down into 3 different components. We have disordered eating here, amenorrhea, and osteoporosis. That's what they said made up this triad. And they were really focusing on your younger adolescent athletes. And then around 2004, we then decided to expand this definition. So instead of disordered eating, we had low energy availability, kind of gave it a little bit more of a broad ability to put female athletes into this category. And then instead of osteoporosis, it was actually low bone density. And instead of menstrual dysfunction, it was amenorrhea. So this expanded the definition and really expanded our ability to help athletes. And what they did was they created almost a sliding scale model. So if you look on the right side, you have optimal energy availability. That is where we want all of our female athletes to be. They're taking in enough calories, they're not burning too much. It's this perfect equilibrium. And then you also have optimum bone health. So if you're putting in enough fuel and you're not burning too much fuel, you're going to have this perfect bone health. And if you then your periods, your menstrual cycle will be regular. Now, a female athlete can be anywhere on this sliding scale. So this is the ideal in the green, and you can go all the way over here to the red. This is where you have the osteoporosis, no periods, and then sometimes even a clinical eating disorder. So you can see here how this is way more versatile than the previous triad that was very, very strict. So Elizabeth Joy and her colleagues at the University of Utah created in 2009 one of my favorite articles. It was the first big mention. It was in the American Family Physician about health-related concerns of the female athlete, but it looked at an entire lifespan approach. It didn't just focus on your young in your college. It really focused on every age of the female athlete, from baby to post-menopause to, closer to death. So it was a really, really good article. So I like this picture. This is right and this is wrong. I'm sure my husband and I argue about this all the time, but it brings up a great point. In 2014, Female Athlete Triad Coalition created a consensus statement on the treatment and return to play of the female athlete. So basically, it didn't really change much of the definition, but they just kind of reinforced it. But some people weren't happy about this approach. Some people said, hey, it's not that simple. It's not just periods, bones, and not eating enough and exercising too much. There's more to this. What about the heart? What about the immune system? What about muscles, bones, tendons? What about all of those other things? And also, what about men? So there was a lot of struggle amongst the Sports Medicine Society of which way to go. So then the IOC, the International Olympic Committee, in 2014 created the term relative energy deficiency in sport, also known as REDS, as you guys might have heard it. And if you look at this really cool diagram here, the triad only fits right here. So 3 components: bone health, menstrual function, and then the energy associated with the athlete. Whereas the REDS looks at all of these other things: gastrointestinal, cardiovascular, psychological, growth development, metabolic, endocrine. It really just had a way broader focus. So this definition just kept getting bigger and bigger, and including more female athletes for us to protect. Well, that didn't go over so well. So the people that invented the Female Athlete Triad Coalition were not happy about this whole term REDS. There was pretty much outrage in the sports medicine world about this. So regardless what you think or which direction you are, or if you even know these definitions, the point is protecting our athletes, and that's what we're all here for. So the fundamental purpose of having any REDS or female athlete triad, it starts from low energy availability. And my favorite concept to use is the female athlete is the beautiful Mustang, right? And if you don't put in enough gas and you want her to go from Tampa to Miami, she might not make it. So you got to make sure you're fueling the system and not burning too much. It has to be an equilibrium, and that's where we call low energy availability. So if you're either burning too much or you're not putting enough into the system, that an athlete, female athlete, couldn't be able to maintain her health. And if you have that low energy availability, which is a very extensive little equation, which I'm more than happy to share with everybody after this or answer any questions. If you don't have enough of that enough of that energy availability, you're going to end up with either REDS, triad, regardless, again, what you think it's about. All of those things are possible if you don't put enough fuel in that system. So hopefully everybody understands the whole low energy availability concept, because from here on out, that's kind of where this lecture is going. So what is low energy availability? I don't want anyone to assume that it's always because they just don't eat enough. As we already talked about, sometimes they are exercising too much. Sometimes their activity, just walking a mile or 2 to class, or you find out they're riding their bike to work and to school every day, plus they're training, for their normal sport. Sometimes resting calories can be increased, like how much you're burning because you're ill. Sometimes there's underlying conditions. Also laziness. I had to counsel an athlete not too long ago about how to use a microwave. Absolutely not kidding. This happens. Lack of education. Sometimes they don't know how to cook. They don't know where to get food. Financial troubles. Sometimes there's athletes that, aren't on scholarship and don't have support and, are kicked out of their house. I've heard every story, I feel like, at this point. And then medications. Recently I was challenged with an athlete who I really just did not feel was purposely not eating enough or exercising too much, but had pretty severe ADD and was on 2 different stimulants, an instant release and an extended release. And she just wasn't hungry. It wasn't that she was trying not to eat or had any disordered eating pattern. She legit just wasn't hungry. So that ended up being an issue in itself, and we kind of figured it out, and she's doing a lot better. But this is something I want everyone to consider, that the causes of low energy availability are really limitless. So let's say that the athlete just isn't putting enough fuel in the tank. This disordered eating is on a continuum. So if you look at the left side over here, these are your healthy attitudes and behaviors. So the athlete thinks they're at healthy weight, they're exercising and eating appropriately, they have a good body image. And then as you go a little bit towards the right, you see this yo-yo dieting, excessive exercise, maybe they're becoming a little too preoccupied with their weight, and then sometimes they're fasting and all of a sudden they have gluten sensitivity, and all of a sudden they have use of other medications, or they're trying to do this or that. So you'll start to see a pattern as they go down this continuum. Anorexia, bulimia, binge eating disorder, those are all real. Those are clinical eating disorders that we can't miss. I will promise you, it has seen you. You might not have seen it. So we really do need to kind of put these on our radar, especially in our athletic population. So eating disorders are near and dear to my heart. I love teaching about this. I'm not going to get super into it, but DSM-5 is the psychiatry godsend book, basically. We had the 4 version, and then we had the 5 version. 5 is where we're at right now. And when it comes to eating disorders, there's multiple different categories, but the 3 main one here is anorexia, bulimia, and binge eating disorder. And in the DSM-4, it was almost kind of difficult to fall into one of these categories and one of these actual clinical diagnoses, whereas now in the 5, you don't necessarily need to have a low body weight less than your 85% of expected weight to be anorexic. In bulimia, you don't have to binge or purge as much as you used to fit into this criteria. So something I just want everyone to be aware of are these definitions. So the menstrual cycle, we've already discussed that if you have low energy availability, you're going to affect the menstrual cycle. So if there's not enough energy or not enough fuel in that system, the normal process of the body, which is to procreate, have babies, have your cycle, if that's what you desire in life, won't really work. So you will see changes in the menstrual cycle in these female athletes that aren't getting enough nutrition or exercising too much and have that low energy availability state. So we really need to just kind of understand a few terms. So menarche is the first period that a female has. Usually this is anywhere around 11 years old, sometimes 10 years old, all the way up to about 15. If they don't get their first period by 15, we get a little bit concerned of other things, which we'll talk about in a second. And then here, you all have seen menorrhea. So I kind of broke it down like this to make sense, but if you put EU in front of menorrhea, it's eumenorrhea, and that means normal cycles. And those can last anywhere from 21 to 30, or every 21 to 35 days. And then you have oligomenorrhea, and oligomenorrhea is where they last, there's a little bit more time in between periods, but it's not necessarily a concern just yet. And then you have amenorrhea, so put that A in front of menorrhea, and you can then add primary or secondary. So primary amenorrhea means that a female never got her menarche, like she never got her first period. And that's when you really want to start looking for endocrine disorders and other things outside of the low energy availability spectrum. And then secondary amenorrhea, this is really what we want to focus on. This is our concern today. So if you don't have enough energy available, then what's going to happen is you're going to end up with secondary amenorrhea. So absence of cycles for more than 90 days. So a female athlete will go over 3 months without having a period after she's had her first period. Hopefully that makes sense to everybody. It's very weird not being in a room and seeing the response of the audience. So forgive me if I'm going too fast, but the menstrual dysfunction, this is a great, confusing sometimes little chart, but essentially what happens is if you have low energy availability, you are not going to have a normal flow of this hypothalamic system. So what will happen is if you don't have enough food in, basically enough fuel in the tank, you're not going to make enough GnRH, which is a hormone. And if you don't make enough GnRH, you're not going to stimulate that anterior pituitary to then make LH, which then stimulates the ovaries to make estrogen. So when that happens, you end up being at a low estrogen state, also known as hypoestrogenism. And then again, that leads to your abnormalities in your periods. There is something called the luteal phase defect, and I want everyone to be aware of this too, because just because a female is still getting her period, there's other things we have to think about, and she still could have low energy availability. So I'm not going to get too much into the cycle of the period in the menstrual cycle here, but after ovulation, that's when a female releases a follicle and has the ability to get pregnant. You go into something called the luteal phase, and this luteal phase here is when progesterone increases. So if you have low energy availability, you'll make a decrease in progesterone, and that can lead to infertility and spotting. And a lot of times women who, I would say usually a little bit older, not your adolescent, not in your college, but sometimes your older athletes will have this problem when they're trying to get pregnant and not be able to, and you'll find out that it's really due to a low energy availability, kind of this chronic not eating enough or exercising too much. When it comes to bones, so if you have that low energy availability, you're not going to make enough estrogen, as we already saw from our little chart before. And then this really is going to cause havoc on the bones, and you're going to have a decrease in bone density. So if you look on the left of the screen here, this is your normal bone, and then that bone can become very impaired all the way to osteoporosis here. So low bone density means the bones are just a little bit more brittle, a little bit easier to break, risk of stress fractures, things like that. Something called the Z-score, which is tested through this called a DEXA scan. That's how we look for low bone density. I'm not going to get too much into a DEXA scan today. That's a lecture in itself. But definitely important to know that that is how we test bone density. So I do want to mention that females that do not get a period because of this low energy availability are 2 to 4 times at greater risk of having a stress fracture compared to females that have normal periods. So we're definitely increasing the risk of poor bone health. These stress fractures are going to be localized mostly to the lower extremity, pelvis, vertebrae, but I've seen them, I feel like, everywhere at this point, and I'm sure there's more to come. This picture is your dreaded black line. I'm sure a lot of people have seen this in the tibia and are just cringing knowing how difficult these are to treat. So the cardiovascular dysfunction. So how is the cardiovascular system affected in this low energy availability state? There is some controversy, but one theory is that if you don't make enough estrogen, you're not going to make enough needed nitric oxide. And if you don't have enough nitric oxide, what happens is then a female is at greater risk of getting atherosclerosis. So in future of having heart disease or having heart attacks in the future. Now, if you talk more to the eating disorder world and people that are taking care of clinical eating disorders, anorexia, bulimia, things like that, they might say that that's not true, that it's more of a myocardial fibrosis that you see rather than an atherosclerosis. And I don't want to get too much into the nitty gritty, but the thought is these women are not eating enough. And when they do eat, they're probably eating really healthy. So that whole lipid peroxidation, atherosclerosis thing, it really hasn't been found on autopsies and stuff. So again, regardless, there is heart or cardiovascular dysfunction if you're not getting enough energy. But some of the things I do want you guys to pay attention to is hypotension, orthostatic hypotension from going from sitting to standing, laying from standing, and having that drop in blood pressure. Also just relative hypotension in general. Sometimes you will see bradycardia as well as QTC prolongation. And the reason I have the question mark by that QTC prolongation is that is something that we've been notoriously concerned for sudden cardiac death in the sports medicine world. Now, there has been no proven study showing that anybody who has anorexia and has QTC prolongation ended up having sudden cardiac death without an electrolyte abnormality. Again, I don't want to get too into the nitty gritty, but something I would keep on my radar when we do EKGs, keep an eye out for that, but that doesn't necessarily mean they're going to die of sudden cardiac death. And when it comes to the structural aspects that could change in the cardiovascular system, I already kind of mentioned the fibrosis of the myocardial, and then you can have a reduction in the mass of the left ventricle, and then also the mitral valve prolapse. Again, to clinical eating disorder patients, all of these get better with restoring their nutrition. A lot of times we'll have these patients admitted inpatient and they'll be told that they need a pacemaker, and you absolutely do not want to do that to these young girls. Their bradycardia will get better once they eat more and get their weight back up. So how do we diagnose low energy availability in our female athletes? And this slide is basically just to show how important it is and how prevalent it is. So more than 60 to 70% of gymnasts and endurance runners and dancers have some form of disordered eating. Again, you saw that disordered eating continuum kind of sliding scale. So that could be anywhere from kind of concerning to a full-blown eating disorder, but it's almost 70%. That's a huge number. And then if you look, 15% of them have higher risk of having an actual clinical eating disorder compared to the general population. And if we're talking bone health, 10 to 40% of female athletes have been noted to have low bone mineral density. But I will tell you, I'm not the biggest fan of DEXA scans sometimes, because sometimes I think it gives false hope. I rarely have an abnormal DEXA scan, and I will tell you there is a straight up eating disorder going on and low energy availability. So, you got to use those wisely and not have them kind of blind you from what's right in front of you. When it comes to menstrual dysfunction, there's been some great studies in runners. So the more miles a runner is going to run, the greater is shortening of that luteal phase, the more spotting, the more dysfunction in their menstrual cycle, and then higher risk of that whole continuum of bone health and things like that. So prevalence in female athletes, this is so difficult to assess. One, we don't ask. One, two, we don't know how to ask. There's lack of reporting, there's hidden behaviors, and there's all these other risk factors. So when I say lack of reporting, you'd be surprised, especially if you're not a female, sometimes we don't want to get our periods every month. So sometimes these athletes won't tell us that they're not getting their period because they like not getting their period, and they think we're going to do something about it. Hidden behaviors. When you're dealing with an actual clinical eating disorder, they're very good at hiding these. One, they're sometimes ashamed. Sometimes there's other trauma going on. There's things that they never told anybody. So when you ask in the appropriate way, which we'll talk about later on too, it's amazing what you can find and how they will divulge some of their concerns to you. So where do we come into play? Where do our athletic trainers come into play, the team physicians, coaches, everybody? We really need to detect any concerns of low energy availability early on. This really will prevent any type of progression of the low energy availability becoming a menstrual dysfunction, cardiovascular dysfunction, bone health dysfunction, all of that. So if we can get on this early, we can really do some justice. So a great time to do this is screening during the pre-participation physical evaluation. So I'm sure everybody has seen these, and I make sure that in St. Leo University and USF that there's always questions about when their last menstrual period was. Also, how long their periods last for. Are they on birth control? Are they not on birth control? Are they happy with their weight? Are they not happy with their weight? Do they have a special diet that they follow? All these questions and asking them early on really gets to an early detection. So if you're assessing a history in a female that you are worried for about energy availability or having low energy availability, you really want to ask them about their medical history. Is there an endocrine disorder? Is there something else we're missing? Menstrual cycles, like how long are they lasting? We already went through this. Are they on birth control? Birth control can sometimes lead to a falsely normal period. And then also your progesterone only IUDs can stop a period completely, as can a depot shot, things like that. Psychosocial, like, is there a mental health issue that we're dealing with here? Is there anxiety? Is there depression, OCD? Is there a family history of eating disorders or personally in them? You'd be surprised to find out when you ask, have you ever had an eating disorder? Oh yeah, I've been outpatient for such and such. That's kind of important to know. Also ask about their exercise. Make sure to be specific. Are you exercising outside of what you're supposed to be exercising for your sport? Those questions are very important. And then also nutritional assessment. Are they restricting? Are they all of a sudden gluten-free? Are they all of a sudden a vegan or a vegetarian? Are they all of a sudden intolerant to lactose? Those questions are important. Also, where are they getting their food from? Cafeteria, are they making it? Things like that. And then medications and supplements, as I already gave the example about the ADD and the stimulant medication in the athlete, ask those questions, you'd be surprised. So here's another example of some other questions that everybody can consider asking. And then also on the right here, there's something called the Eating Disorder Inventory 3. And this is a great screening tool that really asks questions that you might not be comfortable asking out loud. So if you have to just kind of hand this and say, hey, I'm a little bit concerned, maybe you're more comfortable asking this way. That's something to consider. There's a bunch of tools like this. This is just one example, and I'm happy to share any type of pamphlets or anything that I have. So physical exam findings, this is very important, especially when you're a little suspicious that something's going on and maybe the history didn't really go the way you wanted it to. This is an extensive list. I do not expect anybody to remember this. This list is from your actual eating disorder specialist. So things I do want everyone to kind of be, aware of is your female athlete that's always cold or always weak or having pre-syncopal episodes, hot flashes, sweating episodes. Those are all things to think about. She might not be getting enough energy. She might really just be doing a lot of damage to her body. And then oral and dental, this is very important. If you find out all of a sudden that there's lots of canker sores or lots of cavities, you got to be suspicious of bulimia and the acid after they have self-induced vomiting. And then also your cardiorespiratory, we already talked about bradycardia and the orthostatic hypotension and the other hypotensions, but also heart palpitations, swelling. There's something called pseudo-Barrett syndrome. So after bulimic stops being bulimic suddenly for a few days, they actually will swell up so bad and so painful. It's horrible to watch. So that's something to consider. GI symptoms, epigastric discomfort all the time. Are they bloating? Are they getting full frequently? Reflux. All these things are very important to consider and note on the exam. Also, are they complaining of a low sex drive? Are they having stress fractures, not able to get pregnant? Things like that. Also, is there depression, memory loss, poor concentration? You'd be surprised of how many female athlete triad or reds that I end up seeing through concussion center, because a lot of these symptoms and this emotional distress comes out, and then you end up getting a lot more information. And then dermatological things, you look for poor wound healing, brittle nails and hair, hair loss, things like that. I like this one too. I feel like we always get this on one of our boards, but something called keratoderma. I can't even say it, but basically that beta carotene in the body from like sweet potatoes and things like that, they'll actually start to turn a little bit orange on the palms of their soles and their feet. So your team physician will most likely order some labs. You don't have to memorize all of these as well, and they're different depending on maybe what's causing the low energy availability. But you want to look at protein and glucose and potassium and sodium, chloride, calcium, all these different things. We already talked about the ECG and looking for cardia, and then QTC prolongation. And then thyroid dysfunction, sometimes amylase and lipase, which are enzymes made by the pancreas, can be high. And then also it's sometimes important to rule out other causes. So you want to look at the hormones. Don't get confused if you find normal hormones. They're very common to have low energy availability and totally normal hormones. And sometimes if they're on birth control, specifically oral contraceptives, these LH and FSH may have a little bit of abnormalities, which has nothing to do with their nutrition status. There was a great study that came out recently by Stanford that was mentioned by ACSM, and it showed that a great proportion of females who had energy availability that was concerning had a decrease in their total T3, so one of their thyroid levels, and this was also correlated with a low bone mineral density. So the Female Athlete Triad Coalition, they created a consensus statement in 2014, and this is one of my favorite little flow charts. I use it all the time. So basically you want to start up here with your history and exam, which we talked about, and then ATC and the team physician kind of come together and figure out what we want to order. But I must say, you have to make sure to rule out pregnancy. There's been times that this has been missed that I have seen, and it's very important if you have an athlete that's not getting her period, you're worried about low energy availability, that you make sure she's not pregnant. And then after that, we can move forward. Depending on what those labs show, this is just an example of the other diagnoses that could be going on. There's something called PCOS, there's something called basically menopause, and then a lot of other endocrine disorders. So working together to kind of figure out what direction to go if it doesn't end up being a low energy availability picture is important. So how do we manage the female athlete with low energy availability? We have to communicate. So this has been a big platform of mine. I work with a lot of amazing male physicians, and sometimes we all need a little coaching on how to talk to females. So it's very important that females, males, whoever you are talking to an athlete, that we do not comment on the appearance. I'll give you an example, but there was an athlete before that was struggling significantly with a clinical eating disorder. She had severe bulimia, and she was at a normal weight, and her weight was slowly going up. Unfortunately, it was because her binging and her purging got worse, not because she was actually taking care of herself. And I saw, somebody go in and say, wow, like, you look great. So that just reinforces a really bad behavior, right? Like, no, you look great, but you don't know what that person's doing to their body to look like that. So just keep it neutral. Just say, you look like you're happy today, something like that, but try to avoid talking about the appearance. And then weight changes should be presented as a side effect, not the illness. Weight loss or weight gain isn't an illness. Not eating appropriately needs to be the focus, or making sure that they're emotionally healthy so they want to eat a better and exercise less, or whatever it is you're working on to manage this athlete. But really not using weight changes as the illness, but rather the side effect. And then using non-judgmental language. So trying not to reinforce not eating or not eating enough, or protein's bad or carbs are bad, or just not doing an all or none kind of approach, not using that judgmental language. And then try to avoid using any type of generic or personal eating advice. This is just not appropriate. And when an athlete trusts you, you might be giving poor information to them that is good information, but maybe just not for them if you don't see the whole picture. And then please don't assume, as I already said, and I say it to all my medical students, residents, and fellows, just because you haven't seen a clinical eating disorder does not mean it hasn't seen you. So please don't assume. If you're not comfortable talking about it, find with your team physician and really just seek to help these athletes. So how do we treat this? So it's low energy availability. We need to intervene, and we need to do this on a nutritional level. So you want to increase their baseline caloric needs by 20 to 30%. This can be calculated with a bunch of different methods. So if you have a sports dietitian, that's amazing. You can work together and really figure out what's their caloric need on a daily basis and how do we increase it about 20 to 30%. So you want to increase their weight by 0.5 kilograms every 7 to 10 days. In severe clinical eating disorders, these numbers are different, so please don't correlate that. That is an inpatient thing. It's called refeeding syndrome. And then you really will see a normal menstrual cycle sometimes just as little as 1 to 4 kilograms of body mass that increases. It's pretty remarkable how quickly they can get better. Something also too, I was on one of the Drexel lectures. I don't know if anyone's on any of those right now, but they're doing it for COVID. And it has been really insightful, and there's been a lot of connections. But I had a sports medicine fellow reach out to me because I made a comment about we need to increase the protein in our female athletes. And I don't know what everyone else is seeing, but I still feel like some female athletes are afraid to eat protein. They're more fruits, veggies, and carbs. And I have reestablished a normal menstrual cycle in so many females just by getting them to eat more protein, just by getting them to eat chicken and replacing that piece of bread with chicken or peanut butter, or having them carry a peanut butter jar around with them. So really don't miss increasing the protein in these female athletes. So when it comes to pharmacological methods, this is very controversial. And I will tell you that the treatment for this is replacing their nutrition, putting more fuel in their tank. That is the answer to all of this. The last thing you want to do is throw them on a medicine that they don't need. But sometimes it has to happen. So after 12 months, if they're not better, this is usually when we start to think pharmacological. Again, there's some conditions like mental health things that we might start medicine on early on, or change medicines such as stimulant medications we talked about already, like an Adderall, and stop those so they eat more, things like that. But when it comes to hormone replacement therapy, really here I'm talking about oral contraceptive pills. A lot of people in the past would put these female athletes on OCPs to reestablish their normal menstrual cycle, and that's not appropriate. It's not appropriate for multiple reasons. One, you're giving them false sense of, hey, I'm better now, my periods are normal, and you could be missing something. I also had a little bit of a debate conversation with a different team physician not too long ago, and how we should not be putting females on oral contraceptive pills. And I can't begin to tell you how much I disagree with that. I think it's still our responsibility, if they want to prevent pregnancy or regulate their cycle, that we do take responsibility for that in an appropriate way, and make sure we're aware that this could falsely give a period back in somebody who has low energy availability. Again, it's something that we all work together and have to do what we're comfortable with as practitioners. There's stuff called psychotropics, and when I say psychotropics, these are your SSRIs, your SNRIs, so your Zoloft, your fluoxetine, your Prozac. I think Prozac, Zoloft, I mean, say those two, same thing. And then your Elvil, sometimes people will be on. Those medications are for your mental health. Also, antipsychotics have been studied in some disordered eating patterns, and that has been helpful. Bisphosphonates, these replenish poor bone density. The problem with bisphosphonates is that the studies we do have shown a potential teratogenic effect, meaning that if a woman is to get pregnant while on these medications or previously took these medications, there could be a problem in future pregnancies. But these studies were done on animals, I must say that. So we're not 100% true, but is it worth, taking that chance? Probably not, when you should just be restoring their nutrition. Calcium and vitamin D is pretty much all over the media right now. Some people think it's the cure all, and some people think it's worthless. I do say that it does help bone health, and if it's something you want to do at certain doses, it's not necessarily harmful. But again, working together and looking at that clinical picture, it's individualized for all athletes. And there's some novel therapies right now. There's something called recombinant parathyroid hormone, or RPTH, insulin-derived growth factor, and leptin. These are all things that are currently being looked at in science regarding females with low energy availability. So how do we help these athletes? We're managing this as a team. And if we want to be successful, it takes incredible athletic trainers who are closest to the athletes, and team physicians, sports psychologists, families, friends, coaches, staff, sports dietitians, dentists, physical therapists. It's endless, and everybody can bind together and really, really help these athletes and hopefully detect it early. So how quickly does it take for them to get better? I like this little chart. So if you're looking from days to weeks, that's all you need when it comes to energy restoring. So if you increase their calories appropriately or pull back a little bit on the exercise, you really can get a reestablishment of energy in days to weeks. And then within the next few months, the menstrual cycle will kind of become normal. And then over the next few years, that bone mineral density will continue to improve. There are some females that have had such a long-standing low energy availability or a clinical eating disorder that ends up being osteoporosis in the future. And the time to build your bones, unfortunately, is the time when this condition is most prevalent. So they sometimes end up in the future with some severe osteoarthrosis, or excuse me, yeah, that too, but osteoporosis, and there's nothing you can do about it. So risk assessment, how do we assess these athletes? When do we say, I'm sorry, you're not able to play right now? Athlete contracts are huge. This is such an underused resource, but it holds them accountable. And these documents can be verbal, it can be written. I usually put them in the chart saying the athlete and I spoke about my concern of their low energy availability. They're going to work with the athletic trainer and myself. They're going to go to the dietitian. They're going to increase their calories by this. And it makes them holds them accountable for these measures to improve their health. And then you check in with them so frequently, and they keep signing the document, and you keep moving forward. And if they don't follow your instructions and your recommendations, they have to understand the consequences. So I think when everything's out in the open, everybody just functions better, and there's a lot more resolution of this problem. So there's limited evidence-based guidelines to really risk assess these athletes, but there are some tools that exist. So this one's one of my favorites from 2014, the Female Athlete Triad Coalition Consensus. So if you look here, it breaks it down into low risk, moderate risk, and high risk, and you get points for each of these, and then you total up the total points. So it looks at, was there a history of a stress fracture? If you got a DEXA scan, is there low bone density? Are they getting their periods? Are their periods, a little bit not normal? Things like that, low bone mineral BMI. And then you total their points down here, and then you can here put them in these categories, and you could say they're fully cleared because they're at low risk, or limited clearance, things like that. So a lot of my fellows like this one a lot. I think it's great too. So I really want to say, please don't forget your male athletes. The prevalence is low, but it is absolutely there. Mostly the same risk sports as for females. So your leanness, your weight categories, all of those are something you really want to, be concerned for in your male athletes. Where should research be directed? I wish I could just spend half of my career just researching this stuff. I love this topic so much, but the etiology and treatment of athletes, including ethnic and disabled populations, really does need to be investigated. Every ethnicity has different types of beliefs in nutrition and exercise and things like that. I had an athlete that was, going through Ramadan and just having to kind of manage her diet and make sure she didn't end up down this low energy availability state during her cross country season. And then also we need to design more validated tools to accurately measure the energy availability in the clinical setting, make it easier to measure these, and then kind of a better understanding of where to go from here. Like, how do we treat these? Is there a universal approach that we can all take? So some take-home points. Our athletic trainers are an absolute essential part of recognizing and treating female athletes with low energy availability. As I've already said through this presentation, you guys are the closest to our athletes. And I know from a personal level, I'd be lost without all of you. You tell me more about our athletes and say, hey, I have a hunch about this. Can you do a little more digging? And if you have that relationship between team physician and athletic trainer, it's extraordinary what you can do for whatever program it is that you work for. So being able to recognize the concerns and how to treat them is very, very, very important. Really utilizing that sports pre-participation physical to kind of highlight those athletes that maybe should be further investigated is important. And then also, next slide, sorry about that. I really want to focus on not missing disordered eating or clinical eating disorder. So if you are suspecting any type of hidden behaviors, please discuss with your healthcare professional. And then also hormone replacement, such as oral contraceptive pills, are important, but we can't allow this to hide this condition. Here's my references, and that is it. I don't know, is there a chat box in here? Because I'm more than happy if anyone has any questions.
Yes, so we have quite a list of questions coming in. So I'm going to go through that, and I do want to let all of the people watching here know if you would like to download the handout. So Dr. Narducci did provide us with a fantastic handout here that would allow you can absolutely go in and you can download that on. Okay, screen that. Okay, perfect. So the first question here, incoming athletes coming in with multiple stress fractures. I know that you did go through a really nice a nice slide with that. Is there a specific number that you would consider as the cutoff? Would you go through and use the calculator and then based on that, if they're in the provisional or disqualifying level, or are there certain other indications for when you would go ahead and bite the bullet on the DEXA scan?
That's a great question. I always ask about stress fractures, and I don't care if it's just one. I definitely do more digging. I definitely do more questions, eating patterns and nutrition patterns and exercise patterns, mental health. So regardless of how many, I always go down that road. I'm very comfortable talking about it. Not everybody is, and that's totally okay. But let's say you're at a pre-participation physical and you have an athlete that has had a stress fracture. I kind of ask and residents that are helping with those to kind of write those names down, and then I'll go back to them later when it's a little more comfortable setting, not so fast paced, and discuss it. There's some different criteria of when to give a DEXA. I'm more than happy to share that with everybody. I don't have it completely memorized, but if it's, your BMI is less than 17, if you've had more than 2 stress fractures, things like that. Again, I think it's very individualized. So I don't have a universal, I always do it when I do this or this. It really depends because every case is so different. Hopefully that answers the question.
Perfect. All right. If you were to have a minor, like let's say, for example, high school age, that you believe has an eating disorder, how would you approach them as well as their parents?
That's a great question. Parents are one of the most difficult aspects of a clinical eating disorder. So it depends on who's addressing it. You have to be comfortable asking those questions. And the big thing, and you'll hear it all the time in medicine, like don't ask if you can't offer help. We really kind of would love to help everybody, but if resources, sometimes it's better to not dive too deep, or say, hey, I'm a little concerned about your eating habits. I think maybe you should discuss it with somebody who's a little more specialized in it. Sometimes I have the parents leave the room. I feel like once you build a relationship with the parents, they're pretty cool about stepping out of the room. You can have that one-on-one conversation with the athlete or with the patient. And then I usually tell the patient, hey, or the athlete, whatever, I want to talk to your parents a little bit about this. What are you comfortable with me talking to them? And it really works well. So I've been a big fan of that approach. It hasn't really failed me. And then we've kind of figure out, are they taking this serious? Are they not taking this serious, and where to go from there?
All right. Perfect. And so how about prior to someone developing a stress fracture? In terms of, in the absence of a diagnosis of a stress fracture, what's your threshold, or when do you decide to withhold an athlete from participation with low energy availability?
So before a stress fracture, was that the question?
Right, yeah, and I think probably, again, going back to the table in terms of doing a risk stratification and point scoring, if you use that as your main differentiator between withholding them, provisional clearance, do you use any other things in terms of your clinical involvement and assessment to determine whether or not they should be withheld?
I think you did a great job of using that chart. I love that chart. I mean, just the points, it's so helpful. I know you use it as well. And it really just breaks it down. Unfortunately, if you do a lot of these, you will start to see this mental health kind of aspect too. So sometimes you do have to withhold them, not just because of low energy availability, but maybe they're at harm for themselves or things like that. When you're talking about your clinical eating disorders, like a bulimia or something, their electrolytes can become so deranged that they do become a concern if they overheat or things like that. So I've had to pull athletes back because of that. But again, those are kind of individualized. Other than that, I use that risk assessment tool all the time.
So, okay, I've got a question here about the athlete contract. If you can talk a little bit more about the wording of it, what type of kind of parts do you include in it, whether it's the nutrition, whether it's eating disorder side, kind of giving a little bit more information as to kind of what that looks like.
Yeah. Great question. I'm so happy that somebody even mentioned the athlete contract, because as I said before, I think it's so underutilized, but really making them take responsibility for their condition, because then they realize, one, this is important. Like, this is not a joke. Like, we need to fix your energy status, this and this and this is going to happen. So what I usually write out is, kind of have a standard dot phrase nowadays in the EMR, right? But it's basically talks about what the condition is, that the athlete understands the condition, that I've explained it to them. It really says that the athlete gets, if they don't restore their energy availability, then they can end up with all of these things, and they acknowledge that. And then it's, okay, let's come up with a plan. So if it's your first visit, sometimes this plan would consist of meeting with a dietitian every week and, you know, maintaining a weight of this amount and then increasing protein by this much, you know, things like that. Not exercising anymore before training is actually going on. So you have to be very specific sometimes. So I think the more specific you are, the better, and the more personalized it is with the athlete and gives them kind of goals. You know, I had an athlete not that long ago, again, clinical eating disorder, and very, very OCD about monitoring everything and wearing her watch and looking at it every time and this and that. And it was just like pulling off the onion, like one thing at a time. So I'd have her every week. I'm like, okay, we're not recording our walking today. You know, we're not doing this. And it was just step by step, and every time I saw her, we had a new contract. So you can actually make a document and have them sign it. Again, you can put it in the EMR. You can just verbally talk about it, like, this is our goals for next time. And then the next time they come, did you accomplish your goals? Okay, you didn't. All right, then we need to talk about it. If you don't do it next time, we're gonna have to sit you out, like that kind of thing. Just the consequences. But I like it written.
So, and so based on some of that, you may determine if they haven't fulfilled their side of the bargain, the biggest kind of carrot that you can hold over them is their participation in the competition. Are there things that anything in addition to your contracted items that you're going to be monitoring? Someone's asking about specific labs, specific vital signs, something that you're monitoring more on a day-to-day or from 1 week to the next basis for those people who are on a limited clearance plan?
Yeah, that's great. Hard question, because I'm not the biggest fan of following all those labs all the time unless there's something that I'm worried about, like they have a very, 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 very low potassium because you're dealing with somebody who's binging and purging or using laxatives or something like that. So don't try and like always follow labs. But sometimes you have to. So if it is that case, then you would. I do not do like consecutive DEXA scans or anything like that. So no. And just wanted to bring up, sometimes, you know, monitoring their weight can end up being a disaster. Like if you're actually dealing with somebody who's struggling with concerns about their weight and a clinical eating disorder, you can't be watching their weight all the time. So it's kind of like, how are you feeling? How are your clothes? Things like that. People around them will definitely kind of get involved. So I always work with the dietitian and then the strength and conditioning and kind of see if they've seen any changes. Hey, yeah, they've been in the weight room trying to get extra peanut butter, you know, stuff like that. If they've done more social stuff, because sometimes they can social isolate, you know, did you go out to eat with friends instead of sitting at home and not eating or not eating enough, like those kind of things. When it comes to heart rate, again, I'm not always checking that unless that's what I'm worried about, or obviously if there's a QTC prolongation, I'm going down a road of looking at other stuff. So kind of a tough question, but aside from the contract and monitoring that, like nothing in particular that's specific for everybody.
And then a last question here. Well, and we'll see the return to running template for cross-country athletes who may have been shut down, may have been not cleared for an energy availability issue. Do you have something that you utilize with those athletes?
I'm so you kind of blurred out in the beginning of the question.
Yes. So it's for those athletes who may have not been cleared, they may have been shut down, and they're now being cleared. Do you have any kind of templates for a return to running program for those folks?
Oh, that's great. I usually just use their stress, like stress fracture return to running. That's kind of what I I've always gone to. I don't have one specifically for low energy availability, but I would just use kind of your slope progression like I would for a stress fracture, calcaneus fracture, metatarsal, things like that. But
Awesome.
that would be something wonderful to create someday if anybody's down for that.
Yeah, and I suspect it's probably going to be different for each individual athlete. What is their typical mileage? Determining what mileage were they at when they developed their injury, for example. I suspect it's
Absolutely.
going to be a lot more individual. Thank you so much. This has been fantastic. Just so much information. I love it, and I love to hear that you're in the process. You're going to be a SEDS expert for all of us. So thank you for being a speaker, and thank
you. I'm just always thrilled to participate. Thank you so much, Doc.
All right.
Thank you, everyone who came. You guys are great. Stay safe and stay healthy.